So I am here in a sponsored session by Health in Code, and I am promoter and the CEO of the company, so sponsored by myself also, about next generation sequencing from diagnosis to prognosis. And I think we can provide some interesting information related to the research on the advance in the understanding of how to apply genetics. So genetics, what are the aims of genetics for us? The diagnosis, of course. The prognosis, is this a good aim for us? And of course, the genetic counseling, everybody says is important for genetic counseling. But what is genetic counseling? I went to Wikipedia, which is a good source, and it says that genetic counseling could be defined as the process by which patients or relatives at risk of an inherited disorder are advised of the consequences and nature of the disorder, the probability of developing or transmitting it, and the options offered for their management and family planning. So it's not only to say an example. Genetic counseling. Your patient has a mutation in the beta-myosin heavy chain gene associated with the development of the disease. Mutations in this gene are one of the most frequent causes of hypertrophic cardiomyopathy. 50% of your offspring will carry the mutation and may develop the disease. This is not genetic counseling. We are not informing about the nature of the disease, the prognosis, the management, or anything. We are saying that maybe there is something. I don't think that in 2012 this is an appropriate approach. How can we do the diagnosis? This is important, and I'm going to talk about this first. Sanger sequencing is the gold standard, but of course here we are talking about next generation sequencing, because it's the novel technique, but also because it seems that it's very, very promising. I am not going to talk about the details, it has been reported, but I want to point that the problem here is not going to be the genotyping, it will be the interpretation. So opportunities with next generation sequencing, I summarize: increased sensitivity, because we screen more genes, more possibility to find the mutations, and also because we have improved the evaluation of each gene. It's a kind of digital approach against the analogic approach that I consider that we can say that is Sanger sequencing. Also, we can study genes associated with overlapping or confounding phenotypes, and I will show an example, only an example, but there are many. But there are limitations and pitfalls, low coverage areas. If we don't cover well, we are not evaluating. This happens also with Sanger. The complexity of the analysis and the lack of validation, this is something that is challenging for us. The interpretation, of course, is more difficult than with Sanger, and the potential increase of false positive results. So we created our own platform, 126, 130 genes related to cardiomyopathies, channelopathies, aortic, congenital heart disease, more than 2,000 exons, 1.77 kilobytes of coding sequence. So we evaluate a lot of genes related to sudden death, cardiomyopathies, channelopathies, inherited cardiovascular diseases. We did our validation, and we did this before we went ahead, because you have to validate what you are doing. So the first study was with the genome analyzer Illumina platform, 44 patients. 31 of them had been previously sequenced by Sanger with a number of genes between 5 and 10. And we use these cardiomyopathies, channelopathies, sudden death, San Marfan and San Noonan patients to validate the platform. So these patients had 349 variants by Sanger, not all mutations. We included also polymorphies to make the validation, substitutions, insertions, and deletions. So of these variants, 338, 97% were detected, 97% of the substitutions, 91% of the insertion deletions, but on 11, 3% were not detected. What is important, all of them were in low coverage areas, with coverage lower than 8 times read the sequence. So the solution for this there are two solutions. The first for us was, okay, we're going to sequence the areas of low coverage, just to avoid these false positive negatives, and the other is to increase the coverage. So we will see this. The specificity of the study, in these patients we have read by Sanger more than 680,000 base pairs, and we have found 9 false positive. This is true, these are in variants that we consider of any significance. So 7 of them were in low coverage areas again, and 2 in good coverage areas. I put false positive in question because sometimes you don't know what is the true answer. And we think that sometimes next generation, and some people is working on this, may have higher sensitivity than Sanger sequencing. So very low positive, so specificity is almost 100% and is almost 100% in high coverage areas. But the solution for this is if you have a relevant variant, just confirmed by Sanger until we are sure that next generation is 100% specific. So the coverage may be a problem. This was with the genome analyzer, this was our coverage with this platform. 137 times is the mean coverage. And you see these are all the different genes. Some genes have low coverage, lower than 15 times. And here there is an uncertainty. So to solve this, we can increase the coverage. So these are the results with the HiSeq. So we changed the technology. Instead of multiplexing more to decrease the cost, we think we can increase the cost a bit, but have a good coverage. Mean coverage now is 800 times. And if you compare, all the genes have a good coverage. And the other thing is that if you compare here is Illumina Genome Analyzer and HiSeq with the same platform, what we have now is that with a similar number of sample sequences in this first evaluation, the coverage, low coverage area were lower than 2%. And probably this is because of small areas that you can find a specific problem. So this is going to even improve. But the problem now, okay, this works, is what is interpretation. It has been said more than 1,000 variants, maybe hundreds of exonic variants, and novel variants, etc. So you need to classify, to interpret. You can put the cut point, okay, if this variant is present in 0.5 of the population, we are not paying attention, but be careful. Some of these variants that are present in more than 0.5 of the population are really disease-causing. So it's a tricky situation. To solve the problem, we created Health in Code to solve the problem of interpretation, not of genotyping. Many people is doing, but we also do genotyping, but the knowledge management is a fundamental tool. And the objective is to give a clinically oriented report, something which talks about the pathogenicity, but not only about the pathogenicity. It has to talk about the previous information available, clinical information about the recommendations if it is possible. For this, an example, beta-myosin heavy chain gene. This is a very well-known gene. We are talking about this in this part of the talk. What is the available information? Anyone knows? I think we know a lot of papers, but what is the final, all the information that is available? How many patients have been described with mutations in this gene? What are the phenotypes? And the question, we have seen the talk about the patients with systolic, with end-stage disease. Are all the patients with mutations in this gene the same? Because we may think, after we have heard in the past years that ACM is unpredictable, and there are no consistent genotype-phenotype correlations. And in this case, genetic studies are even not useful for diagnosis, because if there is no prognostic information, what is the reason to try to find a mutation? So this is a capture of our database. And if you put beta-myosin heavy chain gene and you pass over, you see that you cannot read it, but there are 2,000 carriers with hypertrophic cardiomyopathy. There are 190 carriers with dilated cardiomyopathy, 132 with non-compaction, 17 with late distal myopathy, and other phenotypes. So there are different phenotypes with the mutations in this gene, but there are many mutations in this gene. So if you get to the list of mutations, this is from our data, there are a lot of information. And if you see here, maybe you can read this. For a single mutation, you can pass by, and you see that the information is introduced here with not only the individuals, but also the details on the individuals and their relatives. What is the thickness? What is the outcome? What was the age at diagnosis? These questions that are relevant for the clinicians. In this case, for this particular mutation, glycine 716 arginine, we've got 27 hypertrophic, 4 dilated, 4 non-compaction, 2 restrictive, 37 patients described for this mutation. Not much, but it's interesting. This mutation is within the converter region of the beta-myosin. And this is a region that we know from a long time ago that is relevant, is important in the function of the protein, and there are a number of mutations there. How many? It's difficult to know, every day is changing. And this is important. We have to keep updated. I tell you that in La Coruña, we have found 6 mutations in this region, in 11 different families. Of these 6 mutations, 5 of them have been previously described, so there is information in the literature. And it's interesting to know, is the literature and our experience the same? Was there prognostic significance for our patients? I think so, and I will show you. In total, in these families, we've got 57 patients, and there are 26 cardiovascular deaths. And we consider that those patients who had died before 50 or 45 years with sudden death or cardiovascular death were probably affected by the mutation. But this will not be always true, but most of times it will be. In the literature, there are 24 different mutations, 143 families, 470 patients. Most of them are hypertrophic, but also their diagnosis. So you see that in this same region, in the literature, there are a number of families that is not so small, and we can start analyzing what is the phenotype. And 158 cardiovascular deaths. So this is the comparison of our patients with mutations in the converter region with the literature. And you see what I tell you, this is 40 and 60. 50 years is about 60% survival. In the literature, a bit bigger, a bit higher in our population, but not much higher. So, but there are very similar survival curves that are not good if you compare with other patients with hypertrophic cardiomyopathy. So, converter region seems not to be good. This has been previously said in the literature. This is one of our families. I have shown this several times. Non-compaction, cardiac transplantation, 42 years of age. The sister, I show you, hypertrophic cardiomyopathy with systolic dysfunction and some invaginations here, transplantation 40 years. The father of these two had died in their 40s of heart failure. The daughter of the index patient, I show you, when she was 9 years old, she's got good function, no hypertrophy, but some hypertrabeculation in the posterior wall. They've got a mutation in the converter region, and the mutation I have shown you before, the G716R. And this is the survival curve. We have 2 families only. It's very few to get conclusions. The survival curve of our families is slightly better than the literature, but this is a bad mutation in the literature. If you compare, here we compare all the mutations in the converter region with this mutation. This mutation is worse, and this is statistically significant. So this is not a good mutation in this particular region. This is the girl when she's 13 years old. She's got hypertrophic cardiomyopathy, obstruction, severe obstruction, and I think my personal perspective is this girl in 20, 30 years, maybe she's dead if I don't do anything, or she's developing systolic dysfunction, because this is exactly what is happening in the families described in the literature. I will not give you the details now. Now, our challenge is, first, make a very close follow-up of this girl, because it's not only the family, but the literature and everything, but also to try to discover how to modify this clinical course. Of course, this is clue. This is another family with mutation in this region in our institution. So the girl is 15 years old, asymptomatic. The mother died suddenly 19 years old. The mutation is R719Q in beta-myosin. This is a well-known mutation, bad mutation. But how bad? How bad is it? I show you. This is the girl, 23 millimeter septum, 15 years old, and you see the late enhancement, severe late enhancement. So when I saw this, I thought I have to repeat the Holter again and again until I find a non-systemic ventricular tachycardia and I put a defibrillator, because I am. But when we saw the mutation, this is the information about the mutation. This is the survival curve of our family. Very few cases, we cannot get conclusions. But in the literature, you see this mutation, 30 years of age, 60% survival, 40 years of age, 20% survival. And there are patients dying suddenly between 10 and 20 years. So in this case, my decision is, okay, I was thinking of putting a defibrillator, I put it now. Maybe I am wrong. If you compare this mutation with other mutation in the converter region, we know the converter region is not good, but this mutation is even worse. So there are differences in the mutations. I showed you other patients with mutations in the converter region. These two individuals have mutations in that place. The isoleucine 736 threonine. So the mother has severe hypertrophy, and she's got a defibrillator because of risk factors. And the grandmother also a defibrillator because of risk factors, but she's still alive. This is 20 years old, carrier of the mutation, normal echo, normal ECG. The other is 19 years old, carrier of the mutation, abnormal echo, mild hypertrophy, systolic anterior movement without obstruction, abnormal ECG. They are in the converter region, dangerous. We put a defibrillator? No. Because if you see the literature, this is the literature, is the flat line above. No single death reported. But of course, the follow-up stops at 55, 58 years. There is no information further later. But in our families, there are some deaths. We have several families. We have, I think, 8 or 10 families with this mutation. And we have the events, but when they are 50, 60, 70 years old. And sometimes, like in this case, I show you that if you compare this mutation with other in the converter region, it's significantly better survival. This is statistically significant, what is everybody's asking me to show. What happens in the family? The mother has other mutation in the beta-myosin heavy chains. The mother has 2 mutations. The prognostic of those children is better than of the mother, of course, and the grandmother, and is probably better than if they have other mutations that we have seen in the converter region. So what is the message I want to give you? That I am convinced, because we are seeing the data every day, that there are differences in the survival of different mutations, even in the same gene, but even in the same region. Some mutations are 10 years later. And Elena has shown before that when you are talking about the end-systolic dysfunction, the end-stage disease, there are differences. Myosin binding is not the same as beta-myosin. It's 10, 20 years later. This is very important. When we are talking, it's not the same to have systolic dysfunction when you are 40 or when you are 60. But even in the beta-myosin, there are benign mutations. In the myosin binding, there are malignant mutations. I don't like malignant and benign, but just to understand each other. So if you see, I repeat, our patients and the literature, our patients are better because in the literature there is a publication bias, maybe. But if we exclude from our patients those patients with the most benign mutations that are overrepresented, the isoleucine 736 threonine, then there is no significant difference. So what I show you here is that what I see in my families, when there is enough information, has already been described, even with the bias that may happen with the publication. So genetics, I think, works, and I will show you the last clinical example. This is a patient, 18 years old, who died suddenly. And in the family, the cousin had a previous diagnosis, suspected hypertrophic cardiomyopathy. So the pathology sent this patient to our clinic with these photographs. And they say the reason for the death was hypoplastic right coronary artery. The histology shows no disarray, ischemia in posterior septum and right ventricle. And the cause of death was hypoplastic right coronary artery, ventricular fibrillation, and cardiac arrest. So we sent these photographs to Cristina, who was here before, and Gaetano Tiene, to ask them, because we were not sure of this. And they say that they consider that there is left artery dominance, and this wouldn't justify the sudden death. They couldn't say about the hypertrophic cardiomyopathy from the photographs. So we go to the cousin who is alive. The cousin 29 years old, asymptomatic, has a normal ECG, negative here, positive, negative here, T waves, abnormal progression of the R wave, and doubtful left ventricular hypertrophy, 30 millimeter posterior wall. This is very atypical. So in this case, okay, we go for the genetic studies. 9 sarcomeric genes and are negative. So we don't know what is the cause of the death. Of course, we don't have, we have evaluated the patient who is alive. So we made next generation sequencing. One of the first patients we included who had not been sequenced for these genes, all the panel, and we found a mutation in the plakophilin 2 gene. And this mutation, if you say a mutation in the plakophilin gene, all of you, or many of you, are thinking, oh, there are hundreds of variants in that gene that are not pathogenic. But this particular variant, which is a frame shift, is the cause of ARVC in half of the families we studied in our first study in La Coruña. 10 families with the same mutation co-segregating with the disease, with a number of sudden deaths, variable presentation depending on environmental factors or genetic factors like double mutations. So there is a founder effect, and you know this place. I live in La Coruña, which is up there. This is in Galicia. This is Spain, in the south of, you know this place. And that place is called the Death Coast because of the wrecks of the ships, not because of this. But there's a new reason for this, maybe in Galicia. And this man, who died suddenly, comes from Ponteceso, which is one of the cities that is marked as a previous place. In 60 kilometers, we have 10 families. Probably we have more, because I tell you that we have found another family with this one mutation associated with a cardiac event that was suspected to be by other cause. And in this case, we have even done, collaborating with a group in Valencia, functional studies introducing the mutation with vectors in cellular cultives and several, I won't say you, but there is a mislocalization of the plakophilin and other related proteins like connexin. So this is a pathogenic mutation, and it's likely that in this family, this first man probably had an ARVC that was not diagnosed, and now I tell you, there is prognostic and diagnostic information for the cousin and for all the other relatives, because we have to consider that we are not talking about hypertrophic cardiomyopathy, we are likely talking about ARVC. And an ARVC that we have information about 10 families because and has been also described in 2 families in the literature in France. So, next generation works. It's cost effective because we don't have to do the first step, the second step, the third step in all the patients, and finally it's cheaper. The information is, for me, is the key. Not only for next generation. Problems. Complexity, limited time and capacity of the professional to assimilate, analyze, and apply all the available knowledge. Every day we have something new, and we are the experts. Imagine all the other cardiologists who are managing most of the patients with cardiomyopathies in the world. Continuous evolution of technologies, requirement of investment, formation and increasing capacity for analysis and interpretation. So this requires a specific dedication. So our solutions are to have multidisciplinary team dedicated to the compilation and generation of information and knowledge to be continuously up to date and introducing all this data and systems that with knowledge management systems that allow us to generate the reports with all the information in 30 minutes, not to dedicate 3-4 weeks to read 30 or 40 or 70 papers and then to put all together and finally not getting to any conclusion. And the strategic alliance, commercialization, internationalization is necessary for the sustainable progress. And this is the reason that I am here talking with a company and not a research center. So I think it's my last slide. We are here for helping in the diagnosis, evaluation, and management of the patients, saving time, and helping to translate this knowledge that is over there, and we have to compilate and reproduce, and that you are generating every day with the data we provide with our families, with our studies, with our new genes. Thank you very much.
Thank you, Lorenzo. So I believe that the final message here would be that genetic counts. Okay, so, and of course you have an opponent, which is Barry Maron, who clearly said that genetic doesn't count. And I believe that we cannot really dismiss genetics like, oh, it doesn't count. We have to go deeper, collecting data as well as you have done so far, and keep really showing really a relationship between certain genetic patterns and possibly with the help of next-generation sequencing. And I believe the story is not over. The story is still open, and I believe that during this decade we shall arrive to clarify this issue. Are there questions from the floor? Otherwise, I thank you.
Ross.
Is there one? Yeah.
Thank you, Murphy from Dublin. Lorenzo, thanks very much for keeping the fight up. A lot of people have seen the complexity and given up on it, so thank you for fighting. One quick question: are you including Titan in your panel for DCM, and
Yes.
is that next generation?
Yes, yes. Titan works very well. It's one of the genes that work extremely well. There's very good coverage. And I tell you that we find novel variants in almost each patient. And the interesting thing is that we use the same panel for hypertrophic long QT, ARBC, and congenital sudden death of unknown cause. And we are finding Titan variants in patients with phenotypes that have not been described. And we are finding that there is no co-segregation in many of these variants. And we have even found, it has been described the association of the Titan variants with ARBC. This is a paper by Luisa Mestroni. I have to say that we have found in that paper, there is one family that is real, the only family where there is a kind of co-segregation of the mutation with the disease. This mutation, which is a missense mutation, we have found a truncation just besides this missense mutation in a patient who has a phenotype completely unrelated to this and without co-segregation in the family. So my personal opinion is that Titan is a very complex gene. There is a problem with the annotation of the gene. And if you look in 5,000 genomes or in SNP databases, there is no information because of the problems with the annotation of the gene, and many of the variants that appear that are novel are probably polymorphies. But we need to keep collecting data, evaluating the families, because it's likely that some of the variants are really disease-causing, but many of the variants I am sure, are not disease-causing.
Well, just the final message. I believe we do not need to send patients to La Coruña.
No, never.
Where it usually rains, so I wouldn't advise people, although it's a beautiful area, but the weather is usually unaffordable and unadvisable. But I believe that there is, on the website somewhere where people can connect with you, I guess.
Of course. Thank you for the opportunity, but our ideas, we are working, especially in Spain, we are providing genotyping service for more than 60 hospitals. We have some clients and friends in other places, but our idea is that if you want to sustain this, you need to provide this service to other people. And this service may be to do all the analysis and the interpretation, or maybe the interpretation. And we are working on that area because we think that we think that we are progressing and we are providing new information, and the way we have used is to create the company to be able to do it. So we have the stand there, we can talk. Thank you.